At ASH 2014 in San Francisco, I'm Thomas Baldrick with Dr. James Berenson. He is from the Institute for Myeloma and Bone Cancer Research in West Hollywood. So based on where you're from, the camera, the lights, the microphones, this is all just second nature to you, right?
Well, my wife's an actress, so sort of.
Okay. All right, we'll do our best here. Let's talk about your study, what you did and why you took on this project.
The clinical study we did was to look at a novel combination of an immunomodulatory agent, pomalidomide, with a drug called liposomal doxorubicin, along with dexamethasone. And this work had come out of our laboratory initially. Several years ago, we had shown that giving low-dose Doxil several times a week, rather than the conventional once every 3 or 4 weeks, was much better tolerated and much more active in human myeloma in mice. So we moved to that clinic and we tested that combination with Velcade and dexamethasone. It's very active. And then later on, we did a study using that combination with Revlimid or lenalidomide, showed it was very active. And so as a follow-up, we decided to do this combination, that is doxorubicin and dex without Velcade, and replacing the IMiD Revlimid with pomalidomide. And we've been very heartened to see that the triplet with the pomalidomide, the liposomal doxorubicin, and dexamethasone has achieved excellent activity in patients who were not only not responding to Revlimid combinations, but in fact were refractory. They were progressing right through it. So all these drugs are in a similar class. Lenalidomide and pomalidomide were showing we're overcoming resistance with the addition of the pomalidomide. Because of the success of this trial, literally within the next couple of weeks, we're starting a trial to more precisely answer the question as to whether we can overcome resistance in patients receiving one immunomodulatory agent, that is lenalidomide, by simply replacing it with pomalidomide, regardless of what the other partner drugs are. So in our case, we're focusing on liposomal doxorubicin and dex, but in the study, we'll be looking at a variety of different combinations where patients have failed lenalidomide in a combination, simply pulling out lenalidomide and replacing it with pomalidomide. The basis for this study actually comes from another class of drugs, the proteasome inhibitors, where we published recently, a few months ago, that most patients who fail the drug bortezomib in a combination will simply respond by substituting the other approved proteasome inhibitor, carfilzomib. So we're trying to expand the therapeutic choices for our patients. The options need to keep increasing. We're not curing myeloma yet. We need to keep everybody in the game.
Can you share a few of the key results that you did find with this most recent study?
Yeah, well, we started with a phase 1 where we kept the pegylated liposomal doxorubicin constant, 5 milligrams per meter squares, days 1, 4, 8, and 11. The dex given IV, which I think is better tolerated on those same 4 days, at 40 milligrams. But we escalated the pomalidomide from 2 to 3 to 4 for daily for 21 out of the 28-day cycles. Even though we got to 4 milligrams in the phase 1, we started doing patients in phase 2, and we said, whoops, there was a lot of neutropenia, infections, and we moved it down to 3 milligrams, and we've actually had better activity at 3. It's probably because patients can stay on that. So we're using that 3 milligram dose with the doxorubicin, that's pegylated formulation, and the dexamethasone. The response rates, if you include the minimal responders, the clinical benefit rate is nearly 60%, and this is pretty astounding in patients who are lenalidomide refractory. The drugs have been very well tolerated. We see no hand-foot, like we never do with the schedule of the pegylated formulation of the doxorubicin, and we see no mucositis. And the pomalidomide, we are watching blood counts. Occasionally we're seeing some decreases and requiring reductions in the pomalyst dose and or the doxorubicin dose, but they're easily handled. We have many patients now who are on this trial in complete remission who have now moved to a maintenance formulation of the pomalyst at the same dose they were getting on the trial, along with oral Medrol. So we're very heartened that these very heavily pretreated patients who had failed and were refractory to lenalidomide are long-term, many of them in complete remission.
What kind of risks did you feel you were facing with this combination, and how have your expectations exceeded that?
Well, I think we were a little nervous, Nelly, about the neutropenia, and we were kind of right because the 4 milligram dose gave us a lot. Other than that, we were really not very fearful of it because we'd done so much work with the Pegylated Liposomal Doxorubicin and the Dex with Revlimid before and Velcade before. We weren't really that nervous, just really in terms of neutropenia and fevers and infections.
Thank you for stopping by and sharing, and it's back to work for you, it sounds like, huh?
Yep, back to work.
All right, good. Thank you.